Come on. There we go. Okay. All right, so we'll get through breast cancer, we'll take a little break, and then we'll do OBGYN Jeopardy. Okay? So lots of you guys have been asking, because the test is next Wednesday, just as a update for next Wednesday. You have rheumatology on Tuesday afternoon as well as Thursday afternoon. Both are from 1 to 5, and all of those lectures will be given by Dr. Cowell, who is a rheumatologist down in Naples. So she's coming in, blocked out her schedule, so she's coming in to lecture for you guys from 1 to 5 on both Tuesday and Thursday. The OBGYN test is on Wednesday. I would suggest that you know drugs. I will not ask you dosages, okay? That is for the pharmacologist to ask. If I give you any drug, I will give you both the generic as well as the brand name. Please do not get in my bad habit of only knowing the brand name. Please get in the habit, as it is on boards, of knowing the generic name as well. And randomly, when I said, like in the state of Florida, there's been this many ectopic pregnancies, or kind of random stats that I put, even though they might be horrible, you don't need to know those. That's mainly just to drive home various points, okay? Certainly if there's major disease processes that the percentage is very important to know, those things you should know, okay? Yeah?
What tocolytics did you cover? I don't remember.
I didn't cover a drug. I just covered those as a category in general. No. Yeah. All right, any questions? Okay, here we go. Breast cancer. So breast cancer is the second most common cancer in women. It's second to lung cancer. When we talk about deaths, we worry more so about lung cancer than we do about breast cancer, although most women think in their mind that breast cancer is the most common. We think about that just because we lose women who are even under the age of 40 secondary to breast cancer, and we typically don't lose women under the age of 40 to lung cancer. So that's kind of where your patient's coming from. Breast cancer on a chest x-ray, and she thought she had outgrown her risk. You do not outgrow your risk for breast cancer, okay? She was cute though. So birth to death, the overall risk of breast cancer is about 1 in 8, but that goes directly to your Gale score. So if we just look at the overall population of females, it's typically 1 in 8. Certainly when we look at the risk of prostate cancer in men, it's about 1 in 4. We certainly don't hear as much hype about prostate cancer as we do about breast cancer. But conversely, we typically don't get a whole lot of 35-year-old men suffering from prostate cancer, but we do get that in females, okay? The mean age is about 60 years old. Increased risk, or particularly with first-degree relative, especially if in that first-degree relative it occurred prior to menopause, was bilateral, or if you had it in more than 2. So if your mother and your sister, your mother and your grandmother, 2 sisters. If your mother had it and she was 45 and it was bilateral, all that kind of stuff starts to increase your personal risk for breast cancer long term. So again, nulliparous, or if the first live birth was before the age of 35, and again, no offense, thanks girl. No offense, but nobody really cares if you had your first live child. Nobody, and with regards to this, nobody cares how many times you miscarried. It does not improve or change your overall risk for breast cancer. What makes it worse is if you have never had a child, or if your first live birth was after the age of 35. Early menarche, late menopause. Again, more time for estrogen to be in your system, okay? If you've had fibrocystic changes that have been atypical over time, maybe they've had biopsies and they've been like, well, it's not cancer. It's not normal, but it's not cancer. We'll put a marker in there, and you keep coming back. Typically, those women end up with a higher incidence of breast cancer long term. Personal history of breast cancer, obviously. History of uterine cancer, and if you're white, okay? Typically, all of those are increased risk. Certainly, if we have increased risk of endometrial cancer for women who have had a history of breast cancer. All of those hormonal-driven cancers we need to be worried about. So by the numbers, when we look at 2015, 230,000 women were diagnosed with breast cancer, invasive breast cancer. 60,000 were carcinoma in situ. 40,000 women died secondary to breast cancer, okay? We really don't, if we find it early enough and we find it in later years of life, usually it's not lethal for women. There's certainly several treatment options we have for women. So what do we tell women to do? We typically advise self-breast exams. Whenever they're going to come see their provider, they're always going to get that clinical breast exam. And the recommendation still lies for those women who are over the age of 40 to begin getting a yearly mammography, okay? So you tell them to do a self-breast exam, and you got to teach women how to do this. They may not know. Certainly, just like a woman doing like us doing a clinical breast exam, they have to do it the same way every time, okay? And again, part of it goes to women just becoming comfortable with touching themselves. You know, they have to understand what they're looking for, okay? Oftentimes when you go to various clinics, you know, they'll have breast models for patients to even feel so that they know what they potentially are feeling for when they feel their breast tissue. Higher risk women should get an MRI and a mammogram every year. I would say that you're gonna have a hard time getting that covered by insurance, okay? Most patients will actually undergo a mammography, and then if there are abnormalities, they'll go to ultrasound, and then if that's still not diagnostic, they'll go to an MRI at that point, okay? Yearly MRI screening is not recommended for women whose lifetime risk of breast cancer is less than 15%, which is basically almost equates to about 1 in 8, okay? If we talk about 1 in 8, that's 12%, okay? So again, we talk about the Gale score. You can kind of go online, figure out exactly what your risk is if you're over the age of 35 of breast cancer within the next year. I haven't done mine recently. When I did mine when I was younger, my overall risk of breast cancer was 20% in my lifetime, okay, 1 in 5. So basically, you know, everything that you do that's bad, having your period too young, having family members that have breast cancer, never having kids, I think that's bad, okay? But, you know, it all increases your risk for breast cancer long term. So we talk about lobular carcinoma in situ. Lobular carcinoma in situ is not something that is going to be picked up on mammography. It is within the lobular area itself. This is something that you're going to have to pick up on MRI. So this is a woman who's having a biopsy for something else. Maybe had an MRI, you found this, and now we're biopsying this also, okay? So the reason why they end up going on to develop cancer long term is because usually you just don't find just this. You find this and that, okay? So that's the concern for these women. So they do have a 7 to 11 times higher risk of developing invasive breast cancer in either breast, simply because when you have that abnormality, you're going to have something else that becomes problematic. You're more likely to have another abnormality occur, which we'll talk about, than for somebody else to develop a brand new cancer, okay? Ductal carcinoma in situ, 1 in every 5 new breast cancers are ductal carcinoma in situ. So the woman who was diagnosed with lobular carcinoma in situ, guess what she was actually diagnosed with first? DCIS, okay? Vast majority. So she had DCIS, she had a biopsy. Because the biopsy came back positive, they said, let's go ahead and get an MRI. MRI comes back and shows 2 other lesions. They biopsy the 2 other lesions. Maybe one's DCIS, maybe one's LCIS. Truly, the LCIS would have never been seen on a mammogram, okay? But she had the other 2 lesions. So that's why she ends up getting more surgical intervention, okay? So, and the key thing is almost all women who are diagnosed with this early stage, they will basically be cured. So we have kind of, fortunately, moved into that era, or we're not talking about just treating women for breast cancer. There is that cure rate. They never truly say cured. They say cured when you died from something else. You know, we cured her breast cancer. She died of heart attack, but we cured her breast cancer. And truly, that's what you talk about with any cancer patient. We know what the 5-year survivability is. We know what the 10-year survivability is. Why do we not know beyond that? Because nobody follows. I mean, unless you follow that patient personally, but you don't have a cohort of patients that you're following, okay? So we talk about invasive carcinoma, ICD, or the IDC. 8 out of 10 invasive carcinomas are invasive ductal carcinoma. Basically, it starts in the duct of the breast, and it breaks through the wall of the duct, and then it's going to grow into the fatty tissue adjacent to it. All of the part that can metastasize to the body, to the rest of the body. Remember, breast likes to go to bone. Breast can go to brain, but it's kind of later that it's going to go to brain. It's going to go to lymphatic tissue, okay? Invasive lobular carcinoma, so again, starts in the milk-producing glands. Like IDC, it can metastasize to other parts of the body, but it's not as common. So 1 in 10 new invasive breast cancers are going to be invasive lobular carcinoma. Again, typically a little bit harder to detect because it's in the lobular duct. Doesn't want to break through to the fatty tissue quite as often. Paget's disease. So we talk about Paget's disease, kind of a rare form, but can occur. 99% of these abnormalities are associated with breast cancer. So you kind of get a change to the areola, a change to the nipple. You may have some discharge in that area. You want to see if you have an undergarment. If you do, that's always a bad prognostic sign for these patients. For those patients who have Paget's who have no palpable mass, if you biopsy them, they're probably going to have ductal carcinoma in situ. So again, they should be curable long term. And only 1% of all breast cancers end up being from Paget's disease as the base. So it's not too common. Your treatment is going to be either mastectomy or lumpectomy, and with or without radiation. So a note about that. When you talk about any woman undergoing surgical intervention, when they talk about a lumpectomy, basically they're taking out that tissue and they need to get all the adjacent tissue. In every dimension, so just think about this as being like the center of a golf ball. So in every dimension all the way around the mass, you have to have 1 centimeter margins. And they have to be clean, right? So they have to be clean of tumor. For all women who end up having any, whether it's a lumpectomy or a mastectomy or anything, they end up having a lymph node biopsy because we need to know what their sentinel node is in terms of if they already have metastatic disease to the lymph nodes. If the sentinel node, which is that hot node, so to speak, is negative, good to go, okay? They don't have metastatic disease, you got 1 centimeter margins, rock on, you're gonna see them for follow-up, okay? And most of these women are closely followed up. If we talk about the sentinel node being positive, then typically that woman ends up having, she's still on the table when it's diagnosed as positive, then you end up having to take more lymph nodes. So every time you take more lymph nodes in a female patient, especially, or any patient I should say, out of their arm, the increased risk for lymphedema in that arm, okay? Because you're, again, more aggressively changing the lymphatic drainage from the arm. So again, never do a blood draw on that arm, never do a blood pressure on that arm. It increases the risk for cellulitis long term. Radiation is very age dependent. So the cutoff age is 70. So if you're under 70, they tend to radiate those patients a little bit more often than if they're over 70, especially if we've got like a ductal carcinoma in situ, okay? Chemotherapy directly goes to kind of how bad the tumor was, as well as age. So again, if you're under 70, typically you don't need chemotherapy as long as they got the whole tumor and you didn't have metastatic disease to the lymph nodes. If you're even 72, lymph nodes are positive, here's your chemo, okay? If you're under the age of 70, and even if the lymph nodes are going to be negative, almost always they're going to offer you a couple doses of chemotherapy. The whole goal is to decrease the risk of recurrence. 85% of all breast cancers will recur within the first 2 years. So the first 2 years is kind of like the little party, and the 5 years is the big party, okay? So 5 years, you're more likely to develop a new breast cancer. And even after the 2-year mark, the slough from 85% down to 100 is like, oh, it drops quickly, okay? You're more likely to develop a new breast cancer than a recurrent breast cancer. Okay, so that's why you're continuing to see the patients back. Just because they've even had a mastectomy. And this is my favorite. Women who think they've had bilateral mastectomy with reconstruction as a preemptive treatment to avoid breast cancer 100%, it's not 100%, okay? It's like 99%, but it's not 100%, okay? Because you can get some of that cancerous tissue that